Anz is my name. I'm one of the surgeons here in Brisbane, Australia. For those who don't know me, I'm a trauma and burn surgeon with an interest in complex abdominal wall reconstruction. I have a practice based both at the Royal Brisbane Hospital and I'm also the chair of surgery at St Andrew's War Memorial Hospital. I'd like to thank Rob Jacobs for asking me to speak this afternoon, and I have the honour of being the first speaker today, and hopefully will not steal the thunder of too many of our subsequent presenters this afternoon. But my presentation today is just covering off on some of the more common complications following open ventral hernia repair. So ventral hernias represent quite a significant disease burden within most communities. Just under half of ventral hernias are considered to be incisional in origin, and incisional hernias form within 25 to 39% of patients undergoing laparotomy. The open repair of ventral hernias carries not insignificant morbidity, particularly with concerns around mesh infections, recurrent wound complications including both superficial infection and fascial dehiscence, the development of seromas, enterotomy, compartment syndrome, and chronic pain. And these complications we'll look at a little bit this afternoon. There are several presenters later on in the day who are going to look at some of these in more detail, but we'll cover off on some of the basics now. Wound infection is the leading complication for ventral hernia repair, affecting about 15 to 30% of patients. So we've all had patients who have developed some form of wound infection after surgery. It's classified as, by the CDC as an infection within 30 days of surgery, and the risk factors for developing a wound infection include obesity, diabetes, smoking, prolonged operative time, gut violations, these are both planned and unplanned violations of the gastrointestinal tract, patients who are concurrently taking steroids, and chronic renal failure. Wound infection is an implicated risk factor for the development of recurrence, both associated with deep and superficial infections, and mesh infection is associated with deep space infections. Antibiotics beyond that which is used for prophylaxis has not been shown to reduce the incidence of wound infections, even when antibiotics are carried on beyond the initial prophylactic dose at the time of induction. The management of wound infection really depends on how severe the infection is and where it's located, whether it's superficial or deep. So for superficial infections such as cellulitis, which would be the majority of our patients, these can generally be managed by broad spectrum oral antibiotics. If we have swab results, we can use these to tailor the antibiotic regime to suit appropriate sensitivities, and generally these patients will have their infection resolved within 7 to 10 days. For deep space infected collections such as postoperative seromas or hematomas, we typically need to increase the amount of intervention to resolve these problems, and this often involves hospitalisation, the commencement of intravenous antibiotics, and drainage of any collections need to be considered. This is photos of a patient of mine who developed a large infected seroma after his abdominal wall reconstruction, and this was successfully managed by a percutaneous drain with complete resolution of his sepsis. Other patients, however, may require open drainage, and if there's any necrotic tissue involved, this may in turn need to be debrided and managed with a vac dressing. Mesh infections is one of those things that we all fear, and is one of the leading concerns about the use of implants for the management of hernias, particularly incisional hernias. And these patients will typically present with pain, fever, a draining sinus, or erythema involving their wound, and can be classified as either early or late presenters. The majority do not present early. The median time to presentation is approximately 27 months, with a median of 3.5 months to time to presentation. Of these, about half will be more than 90 days after their index operation, 40% after 6 months, and a third after a year. Early presenters will typically have some other adverse event which needs early intervention, such as a missed enterotomy, a leak, or a fistula. The management really depends on the timing of the patient post-op and the severity of their sepsis. Early presentations or very septic patients will often require urgent surgical management, typically through the drainage of abscesses or debridement of wounds, as we've mentioned previously, explantation of permanent mesh, the use of broad-spectrum antibiotics, and the management of any underlying cause such as the missed enterotomy or fistula. patients who have a delayed presentation, they may be amenable to a more conservative approach. And this will typically involve the use of percutaneous drainage of any collections and the use of prolonged antibiotics. The thing to remember though, if you have frank pass on drainage, it's very unlikely going to be able to salvage a mesh in this circumstance, and often will proceed to surgical management. The use of prolonged antibiotics is key. However, there's no evidence really for how long we should be using these antibiotics. If you look at the studies, depending on which paper you read, it's anywhere between 4 weeks to 6 months. And in my personal experience, we generally require around about 3 months worth of antibiotics until we see a normalisation of the patient's C-reactive protein. Once this is settled, we generally find that the patients remain well. However, some patients will require permanent long-term suppressive antibiotics to maintain their sepsis suppression, and the use of antibiotics to achieve this is really guided by the use of cultures and antibiotic sensitivities. Looking at the outcomes or the success of non-operative management, and I'd have to thank Todd Henneford, you'll see him referenced a few times during this presentation, but Todd's team over at the Carolinas Medical Center looked at this particular question in 2015, and of the patients in their study, they found that the average time to infection from time of surgery was approximately 31 months. Initially, all patients on their study were managed non-operatively, but of these, 86% of patients subsequently failed non-operative care, which is give you an indication of the poor success rate with non-operative management of mesh infections. 16% of these patients subsequently were proven to have fistulas, and of those who fail, the majority, or if you were a smoker, you failed non-operative care. If you had a polyester mesh, you failed non-operative care. However, if you had polypropylene mesh, this was salvageable in 29% of cases, and this 29% also includes patients who remained on permanent long-term suppressive antibiotics. When we break that down into types of polypropylene, those with lightweight polypropylene meshes had a relatively good success rate, about 39% of salvage. However, if you've had a heavyweight mesh, your chance of salvaging that situation was less than 2%. Likewise, patients with PDFE, though we don't see many of them these days, again, the success rate was less than 8%. So if our patient fails non-operative management, clearly we now need to look at an operative solution to the problem. And the primary thing to think about is, why has this patient got persisting infection? Is it biofilm that's got onto the mesh at the index operation, or is there the presence of a bowel fistula or a mesh erosion which is driving the sepsis? And operative management really needs to revolve around excluding the presence of mesh erosions, and then to planning an operation where we aim to explant the entirety of the mesh. Ideally, you want to try and avoid partial debridement of meshes. Typically, that mesh which is left behind, though it looks well incorporated and healthy at the time of surgery, will often contain a biofilm which is not detected at that operation and leads to ongoing sepsis, even if the patient makes initially a good recovery. We need to think about how we're going to control the defect once we remove the mesh. Is there a plan to redo a reconstruction with a bioabsorbable or a biological mesh, or is there a plan to primarily close it or leave it as a laparostomy with a plan for a later definitive reconstruction once the sepsis is resolved? Prevention is often better than cure in these circumstances, and a large part of it has to do with good preoperative optimization. Again, this topic will be covered in more detail, but briefly, we need to make sure that patients will lose weight. They need to stop smoking, control their diabetes, and have good nutrition. And certainly in my practice, we exclude all patients with a BMI of 40 or over, active smokers, or uncontrolled diabetes from elective reconstruction. Operative planning, again, is key, and Todd will talk about this further shortly, but we need to think about what is the correct selection of mesh based on the patient's risk profile and hernia stage. Can we stage this procedure if we're involving the gastrointestinal tract during the time of the operation? Is it suitable for a concurrent repair? If so, what type of mesh will we use? Versus a staged or two-step approach where the gut is corrected first, followed by a hernia repair at a later date. Certainly, again, there's some good evidence from Todd's group that would suggest a concurrent repair with a absorbable mesh will often give better long-term results and less morbidity compared to a staged approach. However, each time, each patient needs to be tailored to their particular needs. Prophylactic antibiotics is mandated in most of these operations, and ideally we want to base the use of the prophylactic antibiotics on the cultures from previous infections if there's been any. The operative technique needs to be appropriately selected, ideally avoiding enterotomy, minimising seromas and hematomas, and there may or may not be a role for drains. Moving on, talking about drains is seromas. And seromas, as we've mentioned previously, are associated both with mesh infections and with superficial infections, and they affect up to a third of patients undergoing open hernia repair. The good news is that 8% will resolve within 3 months of surgery without requiring intervention. A further 15% will resolve with aspiration, and less than 5% will have ongoing collections which require ongoing drainage and subsequent infection. Seromas are much more common after larger open component separations because of the raising of large skin flaps to do these techniques, and there is some mixed data suggests that seromas are much more common with biological meshes than other types. So clearly trying to minimise seroma through a good operative technique and mesh selection is key. Aside from this, prevention with the use of drains, unfortunately, is not really supported by evidence. I certainly do use drains after transverse abdominis releases and open component separations, but I don't use them for retrorectus repairs. The Cochrane database from 2013 failed to find any evidence to support or deny the use of drains. Again, Todd's group a couple of years ago looked at the use of talc sprayed intraoperatively to reduce seroma rates, and they had some success. And again, the use of TISSEAL, there's been some conflicting evidence predominantly around the use of TISSEAL to prevent seromas after abdominoplasty with plastics. However, its role for elective ventral hernia repair remains controversial. Enterotomy is, again, one of the challenges associated particularly with redo hernia surgery, and we find that the rates are likely underreported. Anywhere between 2 to 2.5% of patients undergoing ventral hernia repair will sustain an enterotomy. Majority of these involve the small bowel, but about 9% involve the large bowel. More worryingly though, the injury was missed at the time of surgery in about 20% of cases. Clearly, enterotomy is associated with both a rise in mortality rate, particularly if the injury was missed, and its impact on surgical site occurrences is variable again, thanks to Todd and his group, which demonstrated a 28-fold increased risk of synthetic mesh infections, a 5-fold increased risk of wound infections, and a 16-fold increased risk of recurrence. As a consequence, the Ventral Hernia Working Group recommends the placement of biologics or bioabsorbable meshes in these cases. There's been some advocates for doing a staged operation where you correct the enterotomy, wait a couple of days before doing the definitive hernia repair with permanent mesh, where there's not a lot of data to support this particular approach. Dehiscence, again, can be quite a challenge, is often underreported, and we need to differentiate between superficial and deep. Superficial dehiscence is relatively common. Thankfully, deep dehiscence is not. And the risk factors are the usual suspects of obesity, smoking, and diabetes, particularly made worse if patients taking steroids, if they already have an affected hernia, chronic renal disease. And if you're doing a large open component separation, the raising of those skin flaps and division of skin perforators often leads to flap necrosis and subsequent wound dehiscence. Thankfully, most patients only require local wound care. However, a small group, particularly those who develop a subsequent mesh infection, facial disruption, or flap necrosis, will often need to return to theatre for definitive care. Compartment Syndrome, again, is a relatively uncommon problem. However, we do see it in about 20% of patients undergoing abdominal wall reconstruction. We divide them into intradonal hypertension and true ACS. Intradonal hypertension is broadly defined as blood pressures between 12 to 20 millimeters of mercury, and fortunately, the majority of these patients, their pressures are self-limiting and resolve spontaneously. For those with high expiratory airway pressures or pressures are greater than 20 millimeters of mercury in the bladder, management is typically intubation and ventilation, and usually resolves over a few days. Patients who are morbidly obese, the BMI is over 40 and prolonged operative time are at high risk. Abdominal compartment syndrome is intradermal hypertension plus organ dysfunction and develops in about 11% of patients with intradermal hypertension. It carries quite a high mortality rate of about 68%, and this is largely due to rapid end organ ischemia and necrosis. In the early stages, it's managed by intubation and ventilation with a low threshold for decompressive laparostomy if it's progressing. And again, the risk factors remain as patients with a BMI greater than 43 or operative time more than 280 minutes. Chronic pain, again, is quite a common and disheartening complication associated with open repairs with a high variation between studies. Anywhere between 6 to 30% of patients will experience pain after abdominal wall reconstruction, and the risk factors are usually associated with patients who've had pain preceding their operation, particularly if they're using narcotics pre-surgery. You can expect them to have a stormy course afterwards. Pain which persists after a month or repairs which have significant mesh eventration or fixation are often associated with the development of chronic pain. And a large part of the prevention of this complication involves minimising the need for fixation and closing the defect. So in conclusion, reconstruction of open ventral hernias can be challenging, and the open repairs in particular are associated with a variety of complications, particularly around the wounds themselves. Prevention and early recognition of complications are key to improving long-term operative outcomes. Accurate risk stratification of patients will allow us to appropriately optimise patients preoperatively, select the right procedure, and hopefully use the right mesh to minimise these complications. Are there any questions? Thank you.
Keith, thank you very much. I think we'll keep the questions until the end. We've got some time for discussion. So without much further ado, I'll get them to start running Hugh McGregor's talk. Hugh is another surgeon from Queensland who has vast experience in laparoscopic ventral hernia. Thank you.
Thank you, ladies and gentlemen. Thank you, the organising committee, for giving me the pleasure of speaking again, and congratulations on a fantastic program. I've been asked today to talk on complications in laparoscopic ventral hernia repair. I've been doing laparoscopic ventral hernia repair for about 15 years, and I certainly have had lots of complications. So I'm going to discuss those with you today and share them, and hopefully we can learn to minimise and prevent these sometimes very serious complications. Complications essentially occur in 4 phases. The first is choosing the wrong patient. I'll come back to that later. Primarily, there's 3 issues. Complications on entering the abdomen, during the actual dissection, and after the procedure. On entering the abdomen, minimally invasively with trocars, are visceral and vascular injuries. This is no surprise. It's certainly not unique to ventral hernia repair. I think it is higher risk, however, given the fact that in laparoscopic ventral hernia repair, we need to optimise port position for the actual hernia repair, and often these hernias are incisional with a potentially a higher prevalence of adhesions than de novo surgery. I think another issue that makes laparoscopic ventral hernia repair specifically higher risk for trocar injuries is the fact that most hernias are midline, and most of our standard entry techniques for entering the abdominal cavity are also midline. So this necessitates lateral port placement, and consequently, I think there's a higher increased risk of injury to bowel vessels, other viscera. It should come no surprise to anybody here that gynecologists have the highest rate of trocar injuries. However, this is closely followed by hernia repair and cholecystectomy, interestingly. And it should also not be a surprise to anybody that intestinal injury is the most prevalent anatomical structure to be injured by a trocar, followed closely by bladder, kidneys, vascular, etc. Interestingly, someone there is putting trocars into the lung and heart, which doesn't sound very pleasant. This study from the American College of Surgeons journal from 20 years ago looked at about 630 trocar injuries. I think that's a gross underrepresentation of the probable number. But interestingly, of the deaths following trocar injuries, 20% arose from bowel injury. What they did find is that direct view trocars resulted in less trocar vascular injury, or visceral injury. With trocar injury, there's a 10% delayed enterotomy rate, and of those people, 20% or 21% with delayed enterotomies actually died. And they make that conclusion that bowel injuries often went unrecognised, in which case they are highly lethal. So it's something that we really need to manage a bit better. How I try and prevent complications during entry, I've hit most things with ports. I think, obviously, if you haven't hit stuff with ports, you haven't done enough surgery. But there are ways to minimise that, and hitting viscera and vessels and other things with ports is very unpleasant, especially if it's not recognised. I understand that in many countries, including India, it's necessary to use reusable ports. And not every country has the wealth or the luxury of using disposable ports. However, there are ports that make it much easier to get in the abdomen. And I particularly like this FIAS first entry port by Applied. It has a hole for insufflation and a very good view. Ideally, it would be good to avoid sharp ports. I think we have some other tools which are not always present, but if present, can be very helpful, such as a CT, to assess presence of bowel adhesions and omentum, to make planning optical entry into the abdomen easy. I now use selective use of Verres needle in a modified Hassan sort of position over here, where we exteriorise the umbilical stalk and get in with a stab incision just in the base of the cicatrix, and popping in a Verres needle just a short distance and insufflating the abdomen to 15 centimetres pressure before placing the other ports in. I find that very useful. I've always been taught Verres needle is a dirty word, but it's actually a useful tool. I think with wisdom and age and experience, it's also worthwhile considering, not selecting patients with battle-scarred abdomens. This can be very dangerous. These people can have very substantial adhesions, and often one more scar is not going to make any difference to them. What I also do is I often use the upper rectus on the right as my optical port placement. I think it's very predictable anatomy with skin fat, anterior sheath, muscle, posterior sheath, extraperitoneal fat, peritoneum. And the structures lying below that are generally omentum, but potentially liver. And I think there's less chance of a significant injury, although I have hit the pancreas in that position. So, nothing's foolproof. Intraoperative complications, the most significant and severe complication in laparoscopic ventral hernia repair and or any minimally invasive abdominal surgery involving adhesions is small bowel injury. And it's obviously generally related to how extensive the division of adhesions are. As general surgeons, we're all very experienced at taking down adhesions, but obviously we know that not all adhesions are the same. And where I would spend several hours when I was a young man taking down adhesions only to find that I'd caused a bowel injury, I will abandon that very promptly now with age and wisdom, because the risk of a missed bowel injury and the consequences of that are too severe. And we know that the mortality from a missed small bowel injury is approaching or exceeding 20%. And these patients don't become unwell on day one. They become Small bowel content is pH balanced. It doesn't cause a significant inflammatory response until the second day, and often these people are at home. And early recognition of these injuries is very vital before systemic inflammatory response comes on. The most common vascular injury in laparoscopic ventral hernia repair is inferior epigastric artery injury, while the most common source of delayed bleeding is omental. As a colleague of mine said, the omentum looks like fat and bleeds like liver, and can be a very disappointing little bit of fat. Early identification of the inferior epigastrics is very important, obviously, before port placement and also putting tacks. But it does happen, and anyone who does these has hit the inferior epigastrics. Anyone who does minimally invasive surgery has hit the inferior epigastrics. And a little trick I use, if I haven't needed it for quite some time, but is to use a suture passer to ligate above and below the bleeder. Obviously, in the setting of a major vascular injury, a colleague hit the inferior vena cava with an optical port. Gynecologists have been present after they've hit the aorta. Obviously, conversion to laparotomy and appropriate management of that is important. Post-operative, early and late complications, laparoscopic ventral hernia repair hurts, and it hurts a lot. I often see people talking about their day surgery patients with lap ventral hernia repair. I keep these people overnight. They have patient-controlled analgesia. I often put subfascial local anaesthetic in, which I think works quite well. Some people have minimal pain. Some people, as you know, have a lot of pain. Tap block, some people use them. I generally don't, but certainly slow-release analgesia if they've had significant discomfort. And it's important to remember that patients, even having minimally invasive hernia repair, can have ileus regardless of the approach, and often due to analgesia, pain, pneumoperitoneum, presence of blood, etc. So I start these patients on the first night on clear fluids and feed them the following day if they're proceeding well. Late complications after this procedure relate to mesh infection, seroma formation, pain and recurrence. Mesh infection, in my experience, is usually related to missed bowel injury. There are no salvage options. It has to be removed. I've luckily never had an infected mesh. I've been dragging mesh through the abdominal wall as per Nick O'Rourke's paper from 10 years ago for many years and haven't had any infections. So a seroma formation is an inevitability. It's basically the size of the seroma. Obviously, you can minimise the seroma by incorporating the sac into the closure suture to close the defect intracorporeally. They're often inevitable. Large seromas I wouldn't touch unless they were causing problems, because we don't want secondary mesh infection. Pain, I think, long-term is more related to permanent fixation. I try and avoid metallic fixation, but sometimes it's unavoidable. I think I have seen quite a few patients from colleagues who have anterior cutaneous nerve entrapment or scarring related to high velocity dissolving fixation. And I think that's something to consider as well. And also, of course, poor mesh fixation or mobile mesh causes pain. Recurrence, we're all going to get recurrences, we all have. It's important to select the correct patient, correct mesh and correct fixation. It's important to give equal distribution of fixation. It's important to remember that transfascial fixation can cause hernias by cheese wiring through the fascia, and you can, of course, get port-side hernias. Coming back to choosing the correct patient, I think it's important to choose the correct patient for this surgery. Patients with minimal previous surgery, fatter in fact is better. Laparoscopic ventral hernia repair is very useful for very obese patients with small problematic hernias, and I think defects up to 5 to 6 centimetres. I previously have done defects up to 10 to 12 centimetres. I think there are better options. Obviously, it's very useful for multiple Swiss cheese defects, and but I have learned over the years, the bigger the patient, the bigger the mesh, and the more permanent the fixation. You can't do everything with one technique, though. It's important as hernia surgeons to have multiple things up, multiple techniques in your armamentarium, and I think it's important not to throw the baby out with the bathwater. It is a viable technique. It's very useful, and I don't think it's necessary to hop on the bandwagon of let's keep the mesh out of the abdomen. I just did this little diagram here about fixation. I think this is a big cause of recurrence because it's obviously very easy to tack your mesh with dissolving or permanent fixation on the opposite side to your ports. And I think it's important that that people balance up their fixation. And we know that from a recent work from colleagues in Germany, such as Andreas Koch, who've clearly shown that. Thank you.
Well, that was an interesting talk, as expected, because laparoscopic ventral hernia repair is such a common procedure of interest to all surgeons. It's my pleasure now to introduce a young star from India, Ahem Arora. He's teaching faculty in Mumbai's Grant Medical College, and he's going to talk on extraperitoneal approaches and their complications. Ahem.
Good morning, everyone. Let me start by saying that the adoption of MIS AWR procedures is quite unlike anything we've seen for a while. The combination of a benign pathology with the novelty of a fancy technique has promoted the rapid development and adoption of several procedures all across the world. And while all procedures have complications which are often discussed to death, sometimes at meetings like this, here are a few reasons why we need to pay closer attention to all of these surgeries and their eventual outcomes. While there is some overlap, several complications following AWR procedures are distinct from the prevalent MIS ventral hernia repair at this time, which is the lap IPOM. Now, this is particularly important for someone who's doing IPOMs right now, but is looking to transition to one of these newer procedures. MIS repairs aim to recreate the open surgical counterparts. The structures divided, spaces combined, and even the mesh is placed, they are all the same. But the steps to get there are often very different. So even though the complications I discussed here are essentially the same as in open repairs, we are creating them in brand new ways. If you think about a complication as a destination, we are taking different routes. However, MIS repairs may yet have a greater probability of iatrogenic injury than in open surgery. So we are definitely raising the stakes. I am Ahem Arora, and I come to you from Grand Medical College and Sir JJ Group of Hospitals in Mumbai. Let's begin. For the sake of brevity, I'm going to restrict the discussion primarily to MIS, retromuscular, or sublate repairs, because these are the most popular at present. And their open counterparts, the Reeve-Stopa and open TAR, already have a well-established track record, which is going to help us perform a comparison little later on. Now, complications after these procedures are not uncommon, but as I mentioned earlier, some can be quite unique. Linea alba injury appears to be a pretty common one at that. In an open procedure, one first dissects the two retrorectus spaces and then connects them. You can see each space has a right-angled retractor put within it. So the surgeon has identified both the post-rectus sheets, permitting their safe division cranially as well as caudally. In ETEP, however, the crossover to connect the spaces is unidirectional, meaning that the contralateral post-rectus sheet division is somewhat blind. Even though there are a few visual cues, it's quite easy to see how the step can sometimes produce linea alba division, which is quite high up in the abdomen and may not have mesh cover. You can see the contralateral rectus is just coming into view. In this next case, the surgeon, while performing the crossover, missed an injury in the linea alba before he actually hit the contralateral rectus muscle. You can see a lot of subcutaneous fat is actually peeking through at the top left of your screen. Unfortunately, in this particular case, this injury was not repaired and the mesh did not reach that high up to cover this. So that's a new hernia that's waiting to be repaired somewhere down the line. Similar injuries can also be seen in transabdominal approaches like TARM. In this clip, there's a distinct linea alba disruption proximal to the hernia defect that's on your screen right about now. But the surgeon here realized the error and actually landed up closing the anterior sheath in its entirety with a barbed suture and then covering it with a mesh. You can see the needle is actually going across the iatrogenic injury right now. Another notable complication that's specific to sublay injuries is damage to the neurovascular bundles, producing denervation and atrophy of the rectus muscle. This is one of my old patients who had an ETEP with a unilateral TAR for recurrent M2W2 hernia. He came back just over a year later with some vague discomfort that we couldn't put a finger on, so we decided to scan him. And the scan showed a segmental denervation of the right rectus muscle. Now, I'm not sure how much of this discomfort can be ascribed to this, but I can't quantify any functional defect that's resulting from this complication as well. So unless I find any other reason for it, I have to think that it's a rectus atrophy that's causing the problem. Another unique complication is interparietal hernias. An inability to safeguard peritoneum or closing the posterior fascia under tension may produce postoperative dehiscence, producing an interparietal hernia where the viscera comes into direct contact with an uncoated mesh. You can actually see the postrectus sheets on your screen just lift down like a mesh. Now, this may not be a true recurrence, but it definitely predisposes the patient to all the possible complications of one. There's pain, bowel obstruction, possible strangulation, and erosions as a result of interaction with an uncoated mesh. Now, what is alarming is that this posterior disruption is not diagnosed clinically. You need a pretty high index of suspicion and radio imaging, as you see on screen, to set the diagnosis. Once again, this is a known complication of the open restopa as well, but its incidence is much higher in MIS repairs. Here's a case with a very complex recurrence after dehiscence of both the anterior and posterior fascias after TAM. These two defects in the fascias are also a little offset, which produces an oblique passage of viscera across the abdominal wall. This patient, we went back in open, and Dr. Ramesh Punjani from Bombay and I, we landed up performing a bilateral TAR, and this is the patient's post-operative CT a year later. You can actually appreciate the new mesh that we placed having this little waviness that is deeper to the rectus abdominis and the TA slightly more laterally. But by far the most disabling and challenging iatrogenic injury to repair is from a semilunar line disruption. Now, this young lady had a 4-centimeter primary umbilical hernia, which was repaired using a bilateral laparoscopic TAR as per the operative notes. Not only did she have a retrorectus abscess around the mesh, but she also has bilateral semilunar line injuries, possibly because the operating surgeon got disoriented and landed up going far too lateral with his division. This patient has 2 large hernias, an abscess that needs some sort of management. We landed up performing an open mesh explant and will hopefully perform a definitive repair for the hernia soon. Unfortunately, this is not uncommon. Social media is full of similar images of semilunar line injuries, which can be a real challenge to fix. Now that I've discussed the weird and most dreaded complications of these surgeries, let's see what literature has to say. Most of the published series come from high volume centers with truly masterful surgeons. They report very reasonable and sometimes enviable complication rates. But these good outcomes can't always be replicated in a real world scenario by a different surgical team, often in a different part of the world altogether. Let's start with a comparison of open and Robotars. These are the studies I'm going to be referencing, and you'll notice some familiar and pretty big names in there. So by and large, the operative times are longer in Robotar, but the greater investment of time and effort pays dividends in the form of reduced length of stay. There's no difference in SSI risk, but seromas are definitely more common in the robotic approach, possibly because the ab wall and the hernia sac aren't debrided in open cases, as is the norm in open repairs. This has prompted some to explore the impact of hybrid procedures involving the robo and comparing them with purely open repairs. These researchers found that the operative times are still shorter for open TAR, which makes me wonder if maybe we could invent a robot that can dock the robot faster than a human. Jokes aside, the length of stay for open repairs remains long. The real challenge in hybrid repairs, or the real change, is actually the drop in SSOs. In one of the studies, their incidence was the same as in open repairs, while in Abdu's paper, it was actually much lower, possibly because they landed up excising the excess hernia sac in the open part of their hybrid surgery. This is one paper that I particularly like. It's a more expansive look at the long-term outcomes after open and robotic retromuscular repairs. These researchers found that the quality of life scores improved similarly from pre-op levels between the two groups. There was no difference. Wound morbidity and recurrence risk were also similar. The two groups differed primarily in their length of hospital stay, which makes me feel like eventually the choice between procedures is going to come down to patient pathology characteristics as well as cost effectiveness. Let's take a step back and take a look at SSIs and SSOs. These definitions are pretty broad and very inclusive, which makes it difficult to interpret the numbers. How were any of these events diagnosed? Were the seromas picked up clinically or on imaging? Did they have standard protocols for imaging in the post-operative period? Did the patient even complain about the seroma? What fraction of the seromas and infections actually had an impact on the patient? We don't really know because the prevalent definitions are rather sterile. Excuse the pun. They are great for reporting incidents, but they don't divulge much information about clinical relevance. For example, the image to your left, here's a patient with a small palpable seroma from a lateral hernia that's not causing discomfort, but it's definitely palpable. Here's another seroma in the retrorectus space following an ETEP TAR, which is incidentally seen on a follow-up scan. The patient doesn't have any issues. This, on the other hand, is a large infected seroma with overlying wound cellulitis that definitely warrants attention. But there's no good way at present to convey all of the relevant information. Let's also take a look at the comparative studies that I mentioned earlier. Almost all of them universally mention SSIs, SSOs, and SSOPI rates, along with recurrence, which is a norm when reporting hernia outcomes. These numbers are low, in line with other ventral hernia repairs, but the complications specific to these AWR surgeries find really scarce mention in these papers. In stark contrast, social media platforms are flush with surgeons discussing their own complications or seeking help to manage someone else's. Here is another set of large series of cases from all over the world, including my part of the world, where the reporting patterns kind of repeat themselves. It looks like complications are often underreported, and there exists a clear publication bias where favorable outcomes are reported more often than the real-world adverse events. And truly, it seems like the high-volume centers are publishing way more than the low to mid-tier centers. At this point, I won't go so far as to say that the data is inaccurate. Rather, sometimes it just appears incomplete. Now, I don't want to be a mindless wet blanket and smother the adoption of good surgery, but maybe, just maybe, we need to curb our collective enthusiasm. Each conference has at least one speaker show the Dunning-Kruger curve, and I'm quite happy to be the first one to do so today because it's still early in the schedule. The Dunning-Kruger curve shows that we start off with a lot of enthusiasm and confidence, and we feel like we know everything, but as we notch up the numbers, we realize there's a lot more that we don't completely understand, and true mastery is achieved as a function of time and effort. Where do you think we are as a surgical community with regards to these new procedures on the curve that you see on screen? In my mind, there's two ways this story plays out. One would be similar to that of lap and robotic whipples, where initially centers all over the world adopted the procedure, had some really encouraging reports, and people started performing minimally invasive whipples more and more. But not all centers could replicate the great outcomes. This then prompted the development of guidelines for who should be performing these surgeries. It was based on annual volumes and the breadth of their advanced laparoscopic as well as open surgical experience. The other possibility, and one that I am personally more optimistic about, is that this plays out like lap cholecystectomy, where we had quite a few iatrogenic injuries soon after the surgery was developed, but thankfully they've now significantly trailed off.
It's frozen.
Yes, sir. Yes, sir. Just a moment.
I'll leave you with one thought. The combination.
Sir, the video has been ended.
Okay.
Yes, sir. So
All right.
the next session will be live, sir, from Hanifoot, sir.
Okay, so thank you for an exceptionally good talk, Ahem. We will move on to the last speaker, pair of speakers actually, it turns out. Introducing Todd Hanniford, one of the most influential and legendary figures in modern hernia surgery. So please, Todd, stage is yours.
1 second, guys. I'm trying to share my screen. Thank you very much for allowing me to participate with you guys. 1 second here. Very good. Can you guys see this now?
Yeah.
Yeah, fantastic. So thank you very much, Rod and Ram, of course, and it's great to be in a session with friends. Keith and Hugh I've known for a very, very long time, and look forward to getting to know Dr. Aurora. That's a terrific lecture talking about one of the hottest topics in surgery, not just in hernia repair. But we're going to talk about tonight. We're going to talk about the use of CAT scan and then AI, looking at risk stratification and also predicting complications. And in lecturing with me will be Sully Ayuso. Sully has been in our lab for a year and now is back out in his residency. He's one of our remarkable surgical residents. He just published a paper in JAMA Surgery. And actually has 3 other papers that will be coming out looking at AI and predicting wound-related complications. These are my disclosures. Why a CT scan? Of course, it's available. It's highly reproducible from one institution to another. It's fairly standard, and essentially most of the patients that come in to see me already have one. The expense, it's relatively inexpensive, and I actually considered an extension of the physical exam. And we could give an entire talk just on CAT scan and what to look at in a CAT scan, and how to drive it, use a CAT scan to help drive your care and truly improve your ability to prepare for the operation, prepare your patient for the operation, and then also after surgery, what to look for after surgery. But of course, can it actually predict complications in our patients, and also stratify risk? Of course, all of these types of patients will have had a CAT scan, typically before I actually even see them. Patients like this, with a fistula, easy to see on a CAT scan, but how to get into the abdomen, what intersection of the bowels involved, et cetera, that's pretty easy. Patients like this, whose CAT scan doesn't actually match their operative node, fairly complex operation, supposedly has an intraperitoneal mesh, has a failed external oblique release on the patient's right side, as you can see here. But then as you look down over here, if you can see my arrow down the right lower side, she has tacks outside of her abdominal wall. So again, preparing for this patient, we know that we don't have the full story, and the CAT scan helps put that together. And then also in patients like this, of course, this is a bilateral failed external oblique release with a blowout through the external oblique. And of course, the semilunar has been lacerated here. One of the things that's important here, as you can see in the CAT scan, the midline is actually still together, and you can see on the operative side over here that the midline is together. But one of the things that does help me with in this patient is talk to the patient about rectus muscle function and abdominal wall function after the operation. So this operation is not going to make the rectus muscles work again. They will never work, but it does help me prepare for the surgery, but also help me prepare the patient for what they'll have left. Other things that you can find from preoperative CAT scans, like the assessment of pain, and then other patient assessments, such as patients with concomitant disease, liver disease, ascites, and even sarcopenia. What have we done to try and use CAT scans to predict outcomes? And this was done by Katie Schlosser and Sean Maloney. These are 2 residents that work in our lab. And Katie is actually going to be working with Will Cobb in alpha carbon next year in a fellowship in abdominal reconstruction. She published this in the Surgical Endoscopy about 15 months ago. But what we looked at was looking at subcutaneous volume, total visceral volume, and hernia volume, and looking at could we predict outcomes. Of course, the need for component separation, hernia volume and intra-abdominal volume played a role. The subcutaneous fat did not. But if you look at fascial closure and operative time, hernia volume played a role in all of these, as did the extra-abdominal volume. But when you look at the complications, hernia volume, the volume of the amount of the intestine and omentum, et cetera, outside the abdomen played a key role in predicting wound complications, readmissions, reoperations, recurrence, and even length of stay. And intra-abdominal volume played some role in that. You can see the p-value is not nearly as strong. We had almost 1,200 patients in this study, but the extra-abdominal volume, again, subcutaneous fat, obesity played a role in wound complications, readmission, and the need for percutaneous drain. How about pulmonary failure? Of course, looking at CAT scans to try and predict pulmonary failure. Our rate of pulmonary failure in these big open abdominal reconstructions is just shy of 7%. And pulmonary failure in our hands is not necessarily intubation, but high flow oxygen, especially those requiring admission to the ICU. Body mass index played a role. Age, I had no idea that diabetes would be so important in patients developing pulmonary failure. And then, of course, pre-existing lung disease. But again, looking at the CAT scan, the defect area, as the area got larger, 250 square centimeters, when we broke these down into very low risk, medium risk, and higher risk patients, large defects, look at the hernia volume of over 2 liters. And if you skip down to the hernia volume abdominal wall ratio of greater than 50%, these patients reach high risk for pulmonary failure. And how about weight change? Can you predict weight change? And if I can get a patient like this guy to actually lose weight, putting him back together again, removing the 3 meshes that he had in his abdomen, it actually becomes quite a nice operation and much easier. Just weight loss of 5 kilograms makes a huge difference. 11 pounds, you can see the intra-abdominal volume, total visceral volume, and subcutaneous volume. And with all of this, it helps us get the abdomen closed. But if you think back to the slides I just showed, that if you can decrease these volumes, you can decrease complications. Unfortunately for women, women tend to carry their weight all over. So if you divide this between men and women, men lose a lot more fat involving their abdomen than women do. Women do lose weight and do lose volume in their abdomen, but not nearly as effective as men. One thing that we also learned from this in predicting patients who will actually be more difficult to repair, if you wait to operate on patients, and I'm now, not in favor of watchful waiting for ventral hernias, especially the patients who have long midline hernias. This is part of that paper published in Surgery that Katie had done. If you look at this, is the same patient 14 months later, no change in weight. But if you look at the defect size is substantially larger, and the hernia volume is substantially more. And essentially, this patient is now much more difficult to fix, and you would suppose would carry a higher complication rate. And if you look at the mean change in defect size, just pick 18 months for a midline laparotomy, increase in defect size by 85 square centimeters, and the hernia volume by 550 cubic centimeters, making these actually just a really different animal in trying to repair them. We've tried to try and predict component separations in the past, and this was done by one of our former fellows, Laurel Blair and Sam Ross, who's now one of my partners. It was a rudimentary attempt at this several years ago. Of course, others have tried to look at this. We actually look at the angle from the aorta. Of course, when you see this and you do this mathematically, it does not take the hernia volume into account at all. Here's one by Will Cobb and Alfie Carbonell, where they actually looked at just the width of the rectus muscles and whether someone would need a component separation, a components release or not. But again, it did not include the subcutaneous hernia volume at all in these patients. Could we do better? And so Charbel El-Haj, working with Sully in our lab, started looking at artificial intelligence and deep learning. And of course, the consideration of artificial intelligence and deep learning, can this actually replace some of the what we do as physicians? And this is not a new idea. This was actually first published, in all of these quotes actually came from 1970 in the New England Journal of Medicine. And so, has this been used before? It has. It's artificial intelligence to looking at scans for cancer, and also, even more importantly, for pathological slides, like an evaluation for breast cancer in biopsy specimens. That actually has been used. And what we wanted to do was looking at our previous data, because our previous data actually was just looking at objective data, looking at CAT scan data. In these patients, because our previous data was pretty successful, could we actually use AI and look at just CAT scans and then predict outcomes? And so what these guys did, and Sully will talk about it in a few minutes, but what they did was they took over 350 patients' CAT scans. They took 80% of them and allowed the computer to review these images and gave the answers to the computer. So the computer knew whether the patient was going to have a component separation or not, knew whether the patient was going to develop wound-related complications, and knew whether the patient was going to have pulmonary failure. And then it went through these over and over and over again until it got each test 100% correct. So it looked at 300 CAT scans, and then it did it over 12,000 times until, like looking at component separation, until it looked at every single CAT scan and got it correct every time. And so it took over 12,000 times for the computer to be able to do that. But what is the computer looking at? We actually don't know. You really don't know if it's looking at intestinal volume, hernia volume, subcutaneous volume, looking at the pulmonary cuts. We just really don't know. And so they published this in JAMA Surgery this summer, and it's gotten a lot of acclaim. But again, 369 patients, 80% of the CAT scans were for training, and then the 20% for the test. And then what we found is that in looking at whether the patient will need a component separation or not, the area under the curve of almost 0.75, which was excellent, really quite good. So then what we did was we actually compared it to surgeons. Surgeons took the same test group and looked at the same test group that the computer did, and master surgeons, 6 master surgeons who perform abdominal wall reconstruction and complex abdominal wall repair. Actually, the computer did substantially better. You can see the area under the curve for the surgeons was 0.64 or 0.65 versus 0.75 for the computer. And can they predict wound complications? And this is the data predicting wound complications in these same patients, these 360 patients, and then predicting pulmonary failure. And I love it when our fellows actually have such substantial wins, when you can see that they actually predicted wound infection in nearly 90% of the patients looking at CAT scan once you train the computer to look at these CAT scans. But they called this a fail. If the area under the curve was only 0.55, 55% of the time, it effectively predicted patients who would develop pulmonary failure. I consider that a huge win. Of course, these guys, being perfectionists that they are, continue to work on this. And so for me, looking at where we were to where we are, even if you just look at pulmonary failure, it's substantially improved. And so I'm going to stop here, and Sully's going to take us into the next part of this. And Sully, I will stop, and if you can share your screen now.
That sounds good. Thank you, Dr. Hannaford. So I'm going to pick off where Dr. Hannaford left off. As he said, predicting wound complication or component separation with an area under the curve of over 0.75 is truly remarkable. But what we wanted to do is improve the ability to predict rare outcomes. An ROC of 0.5 essentially is slightly better than a flip of the coin in being able to discriminate a positive versus a negative outcome. So a few things came to mind as we were developing these models is, could we increase the number of images in our data set for our models to train and accurately predict outcomes? And then secondly, just intuitively, when there are more instances of an outcome, the deep learning models that we develop are better able to train because they have more representations of the data. And then the third thing that we thought of after the first project was, how can we integrate the data that we have at Carolinas Medical Center, which is quite robust, to supplement model performance? And so the aim of our kind of second project of many that we're currently working on is to try to improve the deep learning model performance specifically on outcomes that occur less frequently. So we already had one outcome that we could kind of tamper with, which is the pulmonary failure model. And as Dr. Hannaford said, and overall in our data set, it occurs in approximately 7% of patients. Mesh infection occurs in much less than that. And so I think given the fact that that is one of the most devastating outcomes in abdominal wall reconstruction, that was another outcome that we would like to target in terms of outcome prediction. So here's our conventional deep learning model. So the input is a CT scan, so 5mm slices that encompass the entire hernia defect. The model essentially discriminates based on data that is unknown to the user, then extracts features and either puts a patient or a CT scan in a positive or a negative outcome prediction based on the model training and then validation in a separate 20% of the data set. So we reviewed the data science literature, and I think one of the things that was important here is a multidisciplinary collaboration with people that do this much more frequently than we do. And so we partnered with a data scientist to kind of go through the literature and see what was working out there to predict outcomes in other fields for outcomes that occurred, less frequently. Wound complications occur in 20 to 30% of patients that undergo abdominal wall reconstruction. Component separation in our data set, Carolinas Medical Center, is quite common as well. So what we came across is two things. One is image augmentation, so artificially creating images that are based on representative kind of CT scans in this case. And the second one is anomaly detection. So training a data set based solely on the positive outcomes. So that would be things like mesh infection and pulmonary failure. And then in the validation set, where we're testing the model, looking and seeing how well that we can discriminate based on features that aren't characteristic of that positive data group. And so here we have data from approximately 500 patients. That is about a 40% increase from our initial paper. And you see here the number of images that we used was approximately 10,000. Mesh infection occurred in 3.7% of this population. That is almost double of the mesh infection rate in our overall group, but this is a representative sample of 500 patients out of nearly 3,000. And then pulmonary failure you see here occurred approximately 5% of the time. But these are just representative CT scan cuts on the left that we use to input into the model. And so when we looked at the outcome prediction of our conventional model that we published in JAMA Surgery for both pulmonary and mesh infection, the model performed okay, is what I think I would say and what most data scientists would say, with an AUC of about 0.6. Generally, we view 0.7 to 0.8 as good, 0.8 to 0.9 as excellent, and then 0.9 and above is kind of out of this world. And so we wanted to compare how our novel model that incorporated both image augmentation and anomaly detection performed in comparison to the initial model for these more rare outcomes. And what you see here is for pulmonary failure and mesh infection, the area under the curve increased by more than 0.1, which is quite remarkable, and being able to just distinguish positive from negative outcomes. And so when we look at the accuracy, sensitivity, and specificity, you see that the conventional deep learning model that we have already published on was very accurate in predicting a specific outcome. So the overall number of guesses that the model was making in terms of it was very accurate in being able to distinguish that, but it could not pick up very in a sensitive manner on all of the instances of mesh infection that occurred. And so what you see in the pulmonary failure is the same thing. So our kind of novel model that we developed with image augmentation anomaly detection overall was much stronger because it wasn't compromised by decreased model sensitivity. So what was kind of the deciding factor in terms of strengthening model characteristics? So when we looked at image augmentation alone, so this is generating new instances of an image, but training again on the negative and the positive outcomes, we see that this isn't much better than the original model for pulmonary failure. And that was the exact same when we looked at mesh infection, suggesting that anomaly detection, where you train a data set based on just the positive instances of that specific outcome, and then recognizing images that do not kind of look like those, was kind of the driving point for our novel model development being very strong. And so kind of conclusions from this data set, image augmentation anomaly detection, which we term GAN anomaly, which is the term that we're going to use in the paper coming out, was effective in improving model performance for rare outcomes. And that was driven predominantly by anomaly detection rather than image augmentation. Conventional deep learning models are compromised by decreased sensitivity. They cannot pick up on these outcomes rarely. And I think, something that Dr. Hannaford and I talk about frequently is that we train these models based on our data alone. And we feel very confident about our data set being, up to date and prospectively maintained. So we're training models that we feel we're very confident that they're predicting accurately outcomes, which I think kind of is in part the reason that why we've been able to do this so successfully. And so future direction, here is a paper that was published from a group at Massachusetts General Hospital recently in the Journal of Surgical Research. And I really like this quote, and I feel like this is very applicable when we talk about the use of AI in medicine. It is certainly coming, and it is already here. As much as I think we like to run from things that we don't understand, we're not going to be able to in the long term. And so the application of deep learning is not a revolutionary process, but an evolutionary one. And I think all of these incrementations of what we are kind of putting together at Carolinas Medical Center are going to be important in being able to deliver outcome prediction and risk stratify patients at the bedside. So the next step, or one of the next steps for our group in abdominal wall reconstruction, is saying, hey, do these models that we develop work on CT scans from other institutions? So we know that, we are a large tertiary care referral center. We're getting CT scans from all over the state and all over the country. And so these CT scans, are coming from different scanners, et cetera. But the one thing that I think we have going is that we perform repairs in a very consistent manner. We predominantly use pre-peritoneal approach to repair. We predominantly use large mesh overlap, and seeing if these specific outcomes will be applicable when we get CT scans from other institutions and use the outcomes that were recorded by their data sets. So I think another thing to keep in mind, and is very important, is what we're doing better than what exists. Dr. Hannaford had mentioned things that we had done at Carolinas Medical Center in the past. Dr. Carbonell and their group, were predicting the ability to close fascia based on the the rectus muscle versus the width of the defect, and they did that pretty successfully. But are things that we're putting together better than general linear regression? Are they better than things that we put together at our own institution, like the CEDAR app, which predicts wound complications for patients undergoing open abdominal wall reconstruction, or NSQIP, et cetera? And so keeping ourselves honest, I think, is going to be the most important part of this process going forward. And then how can we integrate large-scale data? So we have data from approximately 3,000 patients who underwent open abdominal wall reconstruction, being able to tie in factors that we know impact outcomes, such as, smoking, diabetes, and predicting wound complications, et cetera. That is kind of what's going forward. We have, unfortunately, not been able to augment our outcomes much with that to this point, but I think that's in large part given the fact that we, hold smokers and diabetics to a strict standard before they get operations. So, at our institution, it is mandatory that patients quit smoking 4 weeks before their operation and have an A1C goal of below 7.2. But being able to integrate data points that we might not know impact outcomes yet is something that is certainly on the horizon for our group. And, this is a field that we're lucky enough to have a bunch of large databases that we can draw on and hopefully collaborate with other partners and other institutions to make models that are going to be quite applicable and beneficial for patient care. And so this is kind of, I think the way I see artificial intelligence and deep learning going is being individualized. This is a figure from a paper that was published in JACS not too long ago, essentially predicting outcomes for patients undergoing emergency general surgery. And I think, being able to go through things algorithmic and having, image-based deep learning model predictions as a part of this, where you say, this is the type of procedure that the patient is having, these are their medications, and then kind of go through an individualized checklist for patients, and then be able to have a risk stratified outcome based on many different factors rather than, just one or two things, is going to be ultimately very strong in terms of influencing what we do for patients. And so I think, just to reiterate, each and every one of these projects is going to be important going forward, and being open-minded, but also being honest with yourself about, what these models mean in terms of their ability to predict outcomes, and how well, we trust the data that we're training these off is very important going forward. Thank you guys for allowing me to present. Thanks to Dr. Henneford for always being open-minded to new ideas. So.
Thank you. Well, I want to congratulate all the speakers who have given us food for thought. Whilst we're waiting for some questions from the audience, I'm going to throw one firstly to Eham, and the others can jump in as well. So you alluded to the fact that perhaps the data is not as robust as it might be. So I've always wondered whether we get an underreporting of complications or perhaps an overreporting of complications when we get them from centres of excellence, because they're people doing the work all the time, and therefore you might expect their complication rates to be a bit lower. Or are they more fastidious and finicky, and they pick up all the tiny complications that might not otherwise really be an important thing? I'm wondering what others have to think about that, and whether or not we really know what the complications are.
That's a great question. Regarding the smaller complications that are relatively infrequent, I think it's difficult to convey all of that information within a paper. You want it to be concise and dense, and you want to get some points across, but discussing individual patients with an odd complication a little too much may be a bit distracting. I honestly do feel that the centers of excellence are not having these complications as often as, say, lone or small surgical teams out there in the world. But also, it also comes down to the definitions. So a lot of these patients who are coming back with bulges and hernias, they're going to be labeled as a recurrence. But somebody has to look at the operative videos a little closely and figure out, was this recurrence just a function of the mesh not having great overlap, or was it actually because of iatrogenic facial injury? Because these complications you don't see in the other forms of hernia repairs. These are relatively constrained to the newer AWR procedures that we're seeing right now. So I think we need to be more honest as to what's happening in the OR, and not be quick to dismiss these recurrences as just routine parts of the surgery.
Okay. So I think Romana's got one, but I'm going to ask Todd quickly. So should we stop waiting and just operate if the hernia is going to get bigger, or should we get their weight down? What do you think is more important, getting the 5 kilograms off, or getting in and stopping the hernia doubling in its size?
Well, I mean, I think that there's little question if you operate on smokers, and unless you're going to do this laparoscopically, you're going to be like Hugh and do them laparoscopically or do these robotically, or patients who have obesity or uncontrolled diabetes, you're going to have problems. And so complications in these patients increase our recurrence rate by more than 3 times, between 3 and 5-fold when we're doing them open. And so I press on the patients that it's, instead of saying, go get your life right and then come back, I press on the patients to actually, we need to do this. We need to move this along. And then instead of sending them out and maybe seeing them back in 6 months, now see them back in 45 days, and then recheck with them. And so I'm much more on top of them. I'm also much more likely to send them to. So I'm getting a lot of echo back. Send them to for formal bariatrician consultation, or even bariatric surgery more rapidly than I would have in the past. But I hold them to a standard. I'm not going to operate on if you're smoking. Hemoglobin A1C of 7.2. You need to lose enough weight that I can get your abdomen closed, and every point of BMI decreases morbidity. And so I hold that kind of seesaw back and forth between that and letting the hernia get larger, and converting these people to a much more difficult operation.
Okay. Romana, I think you had a question.
You need to unmute yourself.
Romana, you need to unmute yourself. Ah, there we go.
Hello. Sorry, the question.
Rama, you got the website open as well. That's the problem. Close the website and just go to Zoom.
Okay, I'm sorry about that because I had two on because of internet fluctuations. So my question is for Todd. Are you able to hear me?
Surely.
Yes.
Yes.
Todd, all this unreal computer and artificial intelligence interpretations of images and the data that you feed in, how far are these away from being practically usable for the real world? When do we see another app, and when do we start using these on our own patients? And are there any hurdles along the way?
Well, I think Sully did a good job delineating one of the key factors. One of the key factors in this is surgeons performing the operations differently and then different subsets of patients. One of the things I think of the advantages that we have here that you mentioned is, the people that I work with, essentially we trained them, and we've worked together for a long time. We all do preperitoneal, mesh choice is very equal. We hold patients to a standard. So, within our microcosm, I think they work well. But before we can release these and before Sully can have his first app, which is the plan is that we'll do this, we have to do a multi-institutional trial. And so the CEDAR app works because smoking is bad and obesity is bad and enterotomy is bad and all those things are bad. And but the consideration of whether a preoperative CAT scan will yield post-operative outcomes, I think we have to put it through a multi-institutional trial, and that's what we're currently doing. We've signed contracts with folks. I mean, trying to get this through legal is just amazing, to share information, and it should be difficult. Let's just say, but once that happens, then the answer is yes. We will. When you're being able to take a CT scan and put it into this app and then seeing what these possible complications are, I think it will change an awful lot of the way we talk to patients, even in the consent process. If you're going to have, let's say you work in a small hospital and this patient has a 60% chance of developing pulmonary failure, perhaps that ought to be done in a tertiary center. Or that they're increasing the wound-related complications, you talk to the patient and perhaps the patient decides not to have surgery. The consent process will change as well. Resource utilization, where the patients actually have their operations in the consent process.
Thanks.
I think Dr. Hensman has something he'd like to ask. Chris?
Yeah, Todd, thanks for your presentation and as usual, great insights. My question to you is, in Australia, we are just in the final stages of launching a registry with all of the nuts and bolts of a learning healthcare system that has the power to analyze some of these data points and use artificial intelligence then to predict the kind of things that you're doing. And I wonder whether you could make a comment about that, because I think this is the next step, the nested registry data that can be used to drive options, risk mitigation, and prediction for patients with regard to hernia care.
Maybe I'll pass that to Sully. So Sully has certainly talked about that an awful lot.
Yeah, no, I think that's the goal. Just to kind of reiterate, a couple of things is one, that we trust in our own data at Carolinas Medical Center. The outcomes that we have reported for the studies that I alluded to are completely independent of the surgeons that were performing the procedure. So we have a data collection team that really has no stake in the outcomes that we have for our patients. And then we have a team of researchers who kind of work hard to kind of make sense of the data. And so I think that, when you're talking about more large scale data collection, it has to be standardized in how it's actually collected, and that data is pure enough that if you're doing anything that's algorithmic, that you're, kind of feel okay about, the predictions that are being had. Because if you create a data that is actually predicting outcomes that are incorrect, then that's doing a tremendous amount of harm, potentially for, triaging patients to specific centers, et cetera. I think that, the kind of nuts and bolts of, artificial intelligence and stuff, what we're doing is that you also have to kind of read between the lines a lot of times in the models that are being developed here, because unfortunately, you know, a lot of folks are kind of new to this as we are as well. And you want to make sure that the models that have been developed are, you know, kind of among a certain criteria. The data that we reported both in the paper and then what I just, you know, kind of reported is, you know, averaged out over, you know, thousands of iterations. So this is not just kind of a one-off and being able to detect something. So I would say, you know, to kind of answer that question simply, again, just make sure that the data is being reported accurately and consistently.
It's all about the Chris. It's all about the accuracy of the data. You know, it's interesting to hear Hugh talk about, like, I put it in the pancreas and I put a trocar, you know, in the liver, and I mean, just like when you become a mature surgeon, you're unafraid to say, here are my complications, and here's what I've learned from them. When I was young, I tried to hide everything. I didn't want anybody to know about my complications, and it would hurt my feelings. And so, but, you know, being, you know, accurate data, and you can do some amazing things with accurate data.
Yeah. So look, we might finish there. Look, I want to thank all the speakers. We've had a great first session that's set the tone for the next two sessions, where we're going to hopefully learn how to mitigate those risks and then finally treat the ones that we can't avoid or happen anyway. I want to thank all the speakers, and I'll hand over to the two next chairs, Chris Hensman and Pramod Shind, and they can take it away for the next session. Thank you all.
Thank you.
Thank you, guys.
Thank you.
Great talk, Doug. Thanks.
Thanks, Rod.